Hello, hello. Today we'll have an e-chat on blood purification with the world expert, Professor Claudio Ronco, who is professor of nephrology and head of the Research Institute at the University of Vicenza. He's professor of nephrology at the University of Padova, I should say. So, Claudio, thank you for being with us. You usually have your cappuccino, and this time it will be an e-chat. And I will ask first, as an introduction, blood purification in sepsis. We'll speak about COVID as a specific case a bit later. In sepsis, does it make sense? Otherwise, we need to stop here.
Well, I think it makes sense. I think it does, because indeed, other therapies are not really so successful, and we have the possibility to add some help to patients in different moments of the sepsis cascade. So I think it makes sense, especially considering the pathophysiological foundation of sepsis, what caused sepsis, and what are the mechanisms that develop during the sepsis syndrome.
But people may say, you remove only what's in the blood, but there are so many things happening elsewhere in the body.
Well, the truth is that we have access to blood, but as you know, there is a kind of dynamic movement of molecules across membranes, cellular membranes, capillaries, tissues, and therefore blood is just the mirror of what is happening at the tissue level. And there is a kinetic movement that we are not always able to describe in detail, but for some substances like drugs, urea, and other molecules, we're actually able to do that. So we will be able to do this as well for other like cytokines, where we need to know a little more about generation, distribution, and elimination.
Okay, now, if we remove mediators from the blood, the objection from some people is, do you think you remove only the bad mediators and you keep the good ones? How can you do that? You remove many mediators and you don't know what you remove actually. What do you answer?
This is a typical question that may come from someone that completely forgets that we have innate immunity and adaptive immunity, and we have poussée of or peaks of molecules that are pro-inflammatory, anti-inflammatory. In other words, there is a continuous flow of substances, and the problem is that these molecules are designed to act at the paracrine level, not at the endocrine level. So when you have peaks of concentration of these molecules, whether they are pro-inflammatory or anti-inflammatory, what you want to eliminate is the peak, is the highest level of concentration that somehow resemble what you want to do in electrolyte imbalance, acid-base imbalance, restoring the kind of homeostasis. In this case, you would call this immune-homeostasis.
Perhaps it's a bit simplistic to discuss in terms of good mediators and bad mediators. They have multiple facets, and some mediators may have dual effects, right?
It is simplistic, but we have to start from what we know and what we understand. Certainly, my view is that the possibility to remove aspecifically, in other words, with first order kinetics and removing what is higher in concentration in blood, we are basically trying to equilibrate the response, slowing down the excess, so the maximal deviation from the physiological target.
That's important. We are trying to cool it down a little bit, isn't it?
Yeah.
Now, the next objection is, what is the scientific evidence that it improves outcomes? Show me that it decreases mortality. What do you say?
Oh, well, first of all, I think the idea that mortality should be the ultimate endpoint in trials has gone long ago.
Good.
I think that my suggestion is if you want to target a specific endpoint for an extracorporeal therapy, use exactly the endpoint, which is the claim of that specific therapy. If a therapy claims that is removing endotoxin, you have to demonstrate that you reduce endotoxin. Whether this has an impact downstream in the syndrome is another story. And that's why we are proposing sequential and subsequent therapies. But for the moment, your endpoint should be make sure that the therapy does what it claims to be doing.
Yeah, so it's the right time to speak about the different systems, because those who listen to this e-chat will say, well, okay, but there are several systems. Can you tell us very briefly about them?
Yeah, let me just go in a so-called time cascade of sepsis. If you have invasion of bacteria or viruses, what makes sense is to try to limit the number of bacteria or viruses. We have systems that remove viruses today. We also have systems, biological, like antibiotic, or extracorporeal that can remove bacteria. But then, if you're not able to remove all bacteria, the subsequent point of the cascade will be endotoxin, if it is a gram-negative, for example. So it makes sense to try to remove endotoxin. But then, next step is, if endotoxin is still acting, probably it creates a humoral response, and you have mediators. At that point, we have different methods to remove mediators, which can be filtration, absorption, modified surface membranes. We have different biomaterials that can be used today. And finally, if you're not able to block these steps, you end up with organ dysfunction. And at that point, what you want to do is to support organ. And there is where we apply ECOS, extracorporeal organ support, that can, by modification of the circuit, provide oxygenation, removal of CO2, removal of product accumulated due to liver failure, uremic products, and so on. So I think all the different systems have a logic application, but in a specific time window where the target that you want to remove is there.
Very good. You should write a paper on this, on this personalized approach according to time.
We are planning, and we will do for critical care.
Okay. And then, would you do it once, or is it necessary to repeat these treatments, or to have them for prolonged periods of time, or does it depend on the system used?
I think that today we are a little not very specific for one reason. What we are missing in this equation is biomonitoring. We need to know better what is going on during sepsis. And for the moment, we have measurement of endotoxin, measurement of viral load, we have measurement of mediators. The measurement of mediators is the most misleading, I think, because half-life is very short and so on. And then we have symptoms and signs. Typically, people say, oh, when do you want to apply, for example, in COVID patient, these type of therapies? Well, when I know that there is an hyperinflammatory state, and I know that this patient will end up with hemodynamic instability and organ failure. And indeed, when you apply this therapy, you see a few hours later that you decrease the need of norepinephrine, for example. This is an important sign that shows that you are gaining time for other drugs to be acting. So it is extremely important to try to develop biomarkers, biochemical parameters, and quantify symptoms and signs so that we can use the therapy at the right time.
What about the risk of removing drugs, antibiotics in particular, if it's bacterial sepsis?
we are indeed studying this aspect, which is well known to occur both for continuous renal replacement therapy and for adsorption. And once we have, and we will publish the level of saturation of the curve of saturation, they are called isotherms, for sorbents and for membranes. Once you know that, you will know exactly how to adjust your antibiotic therapy for these patients.
Very good. And so my last question is, what's the future? Will it be more easily applied? Can we be specific about the things we want to remove, like endotoxin, but perhaps other molecules? Shall we use it quite widely in association with ECMO or something else? How do you see the future?
This is a very important question. First of all, I think we should consider that our next generation platforms, machines, will be designed, and some of them are already done like this, to be able to shift from one treatment to another without changing the circuit, without changing too many things, just moving sequentially from one to another. And I will describe in the paper you suggested the possibility to use one single circuit for multiple purposes, so that we can move the patient from one treatment to another. We remove endotoxin for 3 hours, and then we move to removal of mediators, and then we support the kidney, always with the same circuit. This is one option. Second option is, yes, we can be more specific, because we can ask engineers to surface modify and functionalize sorbents and membranes for specific removal. However, we need to know what we want to remove. In the history of uremia, we're still debating what are the molecules that are important to be removed. And in sepsis and in other situations, we still are not sure what we want really to remove. My idea is, rather than going towards removal, it's better to think in terms of re-equilibration, reaching physiological targets. We need to understand better the mechanism, because today, we know that if you put a patient on CVVH and he's in septic shock, 6 hours later, hemodynamics improves, but we don't know why. We have no idea why this is improving, and therefore we need to better understand the mechanism. And the other thing is, we should stop killing important potential therapies because we are not able to design the ultimate randomized trial. Some trials will never be done because there are no money for this. But if we reach some important information, for example, with silica trial or with registries or on the field information, I think this will be important to answer the ultimate question. And it is, if it was you, or if it was your mother, would you apply this therapy? And I think in Italian we say by scienza e coscienza, by science and consciousness. We have to be honest and say, yes, I would. Or if you say no, then you should be the advocate of your patient and not to apply in your patient. But the search of evidence is different from the evidence.
Very good, my good friend. I think that ends our e-chat very, very well. You are a real expert, and your intervention was very clear, right to the point. And we would like to thank you very much. Take care, my good friend. Take care.
Thank you. Thank you very much.
Ciao.